friends. Today we are going to discuss benign prostate. Benign prostate is a very important topic for all young surgeons. I will evaluate the importance for you in few aspects. Number one, you need to know to pass your exam. Number two, it is a common day-to-day problem for which people will consult you. Number three, some of you may not have a full-time urologist in the hospital where you work, and you may have a visiting urologist. So you may have to plan a patient who needs a transurethral surgery. So you should be versatile with all the indications, contraindications, types of procedures, medical management. Prostate has by far in metros gone out of the hands of general surgeons because of specialization, more availability of MCH urologists. But if you are at a district setting, still there is a need for people to know about prostate, because you will have a visiting urologist who will come once in a week. You will line up the cases, and if he has come, he will do the case. So the point is, if you put a wrong case on, you will be responsible for the wrong outcome. Some of you, after training with a skilled urologist in a high volume center, can learn these procedures in a year or 2 years time. Even if you don't get MCH, if you work 2 years with a urologist, you should be able to pick up and perform all these procedures. And above all, having knowledge in all related branches of surgery is mandatory. So with that background, I am discussing the basic issues on diagnosis, investigations, and management modalities. I will discuss in detail the operative modalities, and then in the end we will discuss what are the guidelines in March 2020 and how we can modify our thought process. So when we get a patient, either in your clinic or in your exam or in your OPD, the protocol remains the same. The only secret of success is treat everybody like your long case, and the correct answer will come. So friends, first you should all know the International Prostate Severity Score. These points you have to remember, and only then we can proceed, because every patient is evaluated now mathematically. If the score is from 8 to 19, it is a mild disease. 20 to 35 is a moderate disease, and above 35 it is a serious disease. The scoring you need to welcome Dr. Chetley. And the scoring you need to remember: sense of incomplete evacuation, sense urge to urinate in less than 2 hours, intermittency, hesitancy, weak stream, and straining for micturition, nocturia, and your feeling about if the condition continues as such, are you feeling comfortable, are you feeling miserable, or are you okay? Now this score you have to remember. I am not going into those mathematical things where the data remains the same whether you cram it up or I make you note down. Now coming to the clinical evaluation. On this conjecture, I would like to remind you about a sample history. And a year ago also I talked on this issue. It is worth reminding. When you get any patient for any surgical disease, if you go by sample protocol, you are not likely to miss many things. The sample is, S stands for symptoms, A for allergies. M for medications. Now in prostate, medication is very important. Symptoms I have told you from International Prostate Severity Score, and the score is based only on symptoms. There are no signs in that. And allergy, medication. Every prostate patient who is 65 plus, well, it happens in a now younger age group also, but at 65 plus, there are minimum 6 prescription items which the patient is taking. So you need to initiate all of them in a line, and it is more important if the patient is taking antiplatelets. When you dig the patient, he may think the urologist has nothing to do with diabetes, right? So you need to go in detail about what prescription medicine and what on the counter he is taking intermittently. He may say, well, when you dig in detail, welcome call. So if you continue to dig in, you should get all the prescription items written on the chart. Then P stands for past history. Past history is divided into past medical history, that he had stents 3 years ago, he had a pneumonia 2 years ago, he quit smoking last year, he's dialyzed twice a week, things like that. And then the past surgical history, which will also decide what is the plan you want to discuss. For example, if the past surgical history is that he developed fracture of the hip and following which he developed ankylosing, now that is going to have a big bearing on the type of planning you are going to do for surgery. So past surgical history is very important. And L and E are last meal and event prior to. Welcome, Dr. Patta. Very encouraging for me, you being around. So the sample history in every case when you take, your data will always be complete. Now coming to specific points, you need to take detailed GU history. Other than these symptoms, there are complications of bladder outlet obstruction or LUTS. Say infective complication, patient may have suffered twice orchitis, he might have had acute pyelonephritis, he may be having a lumbar pain because of reflux. So you need to know detailed genital urinary history from one end to the other end. And journal health, his performance status. A 70-year-old man who cannot walk 5 yards is bedridden. For him to undergo any heroic operation is not anything sensible. Then you need to go into details of cardiovascular and respiratory history, which will delineate the underlying disease process, and we should be able to get the pre-existing cardiac and respiratory disease cleared off with help of our cardiologist and pulmonologist. Now when it comes to clinical examination, besides general physical examination, you need to have two things are important. Number one, digital rectal examination. And I would say all of you, even residents, if you are woken up at 2 a.m. and say, speak the steps of digital rectal examination, you should be able to speak in a proper algorithm even at 2 a.m. in deep asleep. You cannot go wrong on this, neither in exam nor in your life. So, digital rectal examination regarding size, consistency, tenderness, median groove, lateral sulcus, upper limit reached or not reached, any nodules if any. So, am I audible? Somebody can type. The focused neurologic examination is another issue. You need to know what is the rectal tone, what are the sensory nerve supply, what is the ankle and knee jerk, because many neurological diseases may manifest as acute urinary retention. I have seen at least 5 patients or 6 patients in my life where Guillain-Barré syndrome presented only as acute retention of urine. While we were investigating, the other neurological signs appeared. Similarly, there are many times the cord tumors, cord compression, which can present as diabetes uncontrolled, can present as neuropathy. Actually, in my training and in my life, for all diabetics of more than 5-year duration and who come with catheter from outside, we always do a cystometrogram to know the diffuser capacity. Now the younger friends should note down few points today. I am going to tell you a basic definition which will solve your all queries and questions on LUTs. Please note down. The normal act of micturition is optimal contraction of optimally distended diffuser with, second point, synchronized relaxation of sphincter, and third point, no distal obstruction. I repeat, 3 items for micturition. 1. Optimal contraction of diffuser. 2. Synchronized relaxation of sphincter. 3. No distal obstruction. So, that is how we are going to work up a patient. Welcome, Vinayak. So, urine examination has importance for RBCs. If any patient is having red cells in urine, he needs further investigation. Red cell in urine in an elderly man, we need to rule out, be sure we are not dealing a RCC or TCC. The positive predictor value of red cell in urine is from 4 to 24%. All patients with LUTs should have a serum creatinine done. And if creatinine is abnormal, means higher, you need minimum a ultrasound and other biochemical workup. Now remember, there is a usual question by examiners. This patient, what are the ultrasonological findings? At this conjuncture, I will conclude the ultrasonological findings in an enlarged prostate. So, your point is to say, sir, first tell the ultrasonological findings of the prostate. Size, nodularity, ecotexture, volume, post-void residual urine. Now when it comes to post-void, we will talk in detail about post-void. But you must tell your, I said it even day before, on when I was talking uroradiology, the post-void has to be checked as per normal physiological conditions. That means you need to do a urge void urine, post-void. Not suddenly tell somebody, can you pass urine? He says, yes sir. He says, go and pass. In that way, a large residual urine will always be picked up in all the cases. Now, the guidelines say, check PSA only if there is a suspicion or it is going to change the line of management. Whereas in our practice, in Indian practice, we order PSA for every prostate because we are more legal minded. And then the ultrasound, after this, the bladder distension, any divertically, and wall thickness, the bladder wall thickness, we will discuss in guidelines, is coming out to be a much bigger issue. And calculating the bladder weight, volume. Then if in a distended bladder, the patient will have dilated ureters. It can be bilateral ureteric dilatation. Now, The renal failure in prostate is of two types, obstructive and infective. So you can have both kinds of kidneys. You may have normal kidneys or abnormal kidneys. If they are abnormal, it can be hydronephrotic, bilateral, one more than the other, or pyelonephritic, small contracted kidneys. So that is the basic ultrasound findings which you should remember at any given time. And if the patient has red cells and ultrasound is normal, then we need to do a CT urography to take care of the upper tract. And if upper tract is normal in a red cell patient, then we need to do cystourethropy to find the cause. Till we do not delineate the cause of hematuria, we should not jump to surgery. When I was a resident, there was two important points. Now, it is worth telling you, because you may meet an examiner of my age. If you are lucky, if you meet an examiner who is 45, 50 years old, probably he is also not grilled in urology and he may not have seen the older editions. There were two terms used. One, decoy prostate. Decoy prostate meant when there was an enlarged prostate and patient had hematuria. So the doctor attributed hematuria to the prostate, whereas the cause was TCC of upper lobe, upper calyx on one of the kidney, or any TCC or any malignant process. Then that means the prostate deceived the doctor. So that was called decoy prostate. The second point was people used to term the hematuria used to be attributed. In those days there were no CT scans. So hematuria after IVP was attributed to the prostate and people used to call this as prostatic piles. These were two old terms which have vanished, but maybe some examiner may be stuck with old terms still. So you should be able to answer if it happens to be like that. Now, further detailed investigations are needed if on catheter removal, patient does not pass urine, has recurrent UTI, gross hematuria, and bladder stone, and renal efficiency, and bladder diverticula. Now, a few words about uroflowmetry. The flow rates are inaccurate if the bladder is not, voiding volume is not more than 200 cc. It is a best non-invasive test, and the peak flow rates are more specific than average flow rate. If the Qmax is more than 15 ml per second, the surgery may not give satisfactory results. And flow rates cannot be, another very important thing which I mentioned you in the definition of voiding. The flow rates cannot distinguish between bladder outlet obstruction and poor detusor contractibility. Because as I said, for a good stream to occur, you need all the three things. Now, few words about post-void residue. It's very variable. Same patient voiding at two different times can have different PVR. PVR does not correlate always with other signs and symptoms. Large residual urine will predict higher failure rate from surgery, because here in chronic retention, more so in diabetes, we need to tell the patient. And again here there is a point of measuring the detusor pressure beforehand. If the pressure is good, you have good result. If the pressure is bad, then patient comes, imagine a patient comes to hospital, welcome Ashwin, comes to hospital with a catheter. We did not bother about the detuser. We removed the obstruction. Patient goes back with the catheter. It is very hard for the surgeon or urologist to face such a situation. So we need to identify beforehand. The transabdominal ultrasound, it is a satisfactory method of assessing post-void residue. These are the guidelines. PVR is an important tool to measure periodically in patients who are on wait and watch policy before surgery. Cystoscopy is indicated in two situations. Number one, hematuria. Number two, when there are signs, symptoms suggestive of distal urethral obstruction. The bladder trabeculations on cystoscopy predict higher failure rate in patients in whom we are doing watchful waiting. And what are the goals of medical treatment? I would like youngsters to write it down, because this is from recent guidelines. Number one, to relieve symptoms of LUTS. Number two, to decrease bladder outlet obstruction. 3, have better bladder emptying. 4, controlling the detuser instability. 5, try to reverse the renal insufficiency. In future, these are the current issues when we are treating a patient with LUTS or prostatic obstruction. In future, preventing 3 things. What are the 3 major things? UTI, hematuria, retention. Repeat. 3 things. UTI, hematuria, retention. So if all these things are taken care, then the medical treatment is okay. With the scientific treatment, having taken a good history, physical examination, sonology and cultures and creatinine with you, let me tell you, if you are honest, only 1/5 patients will require surgery, maybe less than that, depending on what is the population you are you treating as a first filter, or do you get patients who had already had drugs and then failed and come to you. So there is another interesting thing. There is no data to support that higher PVR leads to higher episodes of UTI. The urinary retention episodes are related to, in patients of LUTS, there are more chances of acute urinary retention. Higher the age, number 1. More severe is the score, number 2. Higher is the size of gland. I hope I'm clear. I'm repeating. In a patient population with LUTS, who are the patients who are going to have retention? How can you predict? People with higher age, with higher size of the gland, and more severity of symptoms. Now, having done all this, if we have decided the medical treatment has failed, now Today I'm not going to touch the medical treatment because that is a separate one lecture, because I want each one you have to understand the details of medical management. That will take another 45 minutes. So what are the minimal invasive options we have? Now you don't need to know very detail about it, but at least 4 lines, 5 lines, so that you can speak if somebody asks, what are the other options? You should be able to mention the option and mention the principle behind the option. So let me start. This also the younger friends should note down. Intraprostatic stents. There are 2 types of stents, temporary and permanent. Temporary are biodegradable. So they act like a catheter. The success rate is 50 to 80%. They have their own complications. They can have stone formation, they can break, they can migrate and precipitate sepsis. One greatest disadvantage is you can't do cystourethropy in presence of a temporary stent. The newer stents are used and viewed as a possible bridging arrangement to cover for some time when a patient develops retention following HOLEP. We will come to HOLEP later. Following HOLEP or microwave therapy, then the stents, it is okay to use them for a while when the patient has post-op retention after good resection, so that by the time the edema subsides, the tissues become alright. So to buy some time. The second minimal invasive choice is TUNA. TUNA stands for Transurethral Needle Ablation. Monopolar, just you should know 4 lines, that's all. Rest all is for our urology friends, or you can read or become a urologist with passage of time. So TUNA means monopolar radiofrequency signal, has excellent penetration and uniform distribution. Here the needle is positioned endoscopically as well as through transrectal ultrasound, and radio frequency of 2 to 10 watts is given for 5 minutes per lesion. One lesion is considered as 1 to 1.5 centimeter. 60% patients improve. So we have talked about stent, we talked about TUNA. Third, transurethral microwave therapy. This is to heat up the prostate gland and there are 3 mechanisms of transurethral microwave therapy. 3 ways it helps. Number 1, it leads to hemorrhagic necrosis of prostate. Number 2, it damages adrenergic fibers in the prostate. Number 3, it promotes apoptosis, means natural death of cells. And this has a 50+% response in mild to moderately enlarged prostates. Now the next item is number 4 is laser ablation. We have two types of lasers which are used. And number one, you are supposed to know for your theory exam also a reasonable amount about all lasers. So I will not divert today on lasers because lasers have been already a topic, and MAPC updates, at least two of them have discussed laser very well. You don't need to read any other book for lasers other than update. So we have two types of lasers. One, PVP laser, that is photosensitive vaporization of prostate. Here KTP laser is used. There is no tissue removed. The prostate is vaporized. So we don't have histopathology. So this didn't become very popular. Though it was a cheaper laser, but didn't become popular. So you must write down the advantages of HOLEP laser. It is more effective than KTP laser in management of acute retention. Can be used in patients who have been on aspirin and clopidogrel for their cardiovascular or CVS disease. More tissue is removed this, and there is a data to support that till 6-7 years this works well. More time will tell us more data. The enucleation. The HOLEP laser enucleates. The word HOLEP comes from hole means holmium, E means enucleation, P means prostate. That is how the word HOLEP has become. Similarly, you should all know, is a common question in the exam. When you say laser, he says, doctor, what the laser stands for? So light amplification by stimulated emission of radiation. This you should be able to answer at any given time. Till this time, I will now switch down to the commonest procedure done for prostate. As I said, if you are a hardcore general surgeon, you have to evaluate which patient goes to the urologist for the procedure. And if you are a district surgeon, somebody comes and does TUR in your hospital and goes away, then you should be knowing all the pre-op and post-op workup, all the complications, how to anticipate and how to manage them. So, transurethral prostatectomy is a gold standard technique, evolved over last 40 plus years. John P. Blendy isolated urology from general surgery in England. He was the godfather. In our learning era, we used to all read John Blendy's book. And still, for educational purposes, I have taken out my John Blendy to take you a small journey through TURP. There's no other book which can give you this much knowledge on transurethral. So move with me. The journey is beautiful. This book is around 39 years old, and I see how the books are well maintained. And after 39 years, I don't know how many times it has been photocopied, because so many residents have photocopied this book. And as I said, doctors are selectively poor. When it comes to wine, they will take the best one. When it comes to car, they will not be second best. When it comes to books, they will say, can I have a photocopy, Sharma? Right? So that's this. So let us move with me. For next 5 minutes, I am taking you to a journey to John Blendy. And before we move to journey to John Blandy, we must take these are two of my teachers and Dr. Ashutosh Kumar, who were instrumental in my training. So, this is the prostate. On open prostatectomy, with the scissor we dissect between the capsule and the prostate gland. In transurethral, you are cutting chips from the bladder neck area to the virumentum. See, the whole skill of transurethral surgery is working between the viru, sphincter and the ureteric meatus. You should not be cutting either this or that. So that is all skill. Broadly, the transurethral is, first step is to remove the lobes, second step is to remove the apical tissue, the last one is to give finish to the cavity. This is the broad principle for you to understand. Whenever there is a median lobe, so that the sheath can move in and out, you need to tackle the median lobe first. If there is no median lobe, or once you dealt the median lobe, then this picture after resect becomes this. You cut till the circular white fibers of capsular tissue are seen. Now, all the bleeders should be coagulated pinpoint. The pinpoint coagulation is, you reach there, you put their loop, press it. When with the pressure the bleeding stops, then you coagulate. Don't coagulate randomly over a large area. Then there is a term called crossfire. A bleeder from here will hit this wall. So to you it will seem the bleeder is here, whereas the origin is here. You may have large venous sinuses. If they so open up, put a catheter and interrupt, because that will lead to a lot of mobilized water absorption or the glycine absorption. Now, a good method is, this was popular even when I was a resident. That means even in 79, people knew about this. That you start at the apex at 12 o'clock and keep cutting till you get a capsule. When you get the capsule, then you travel along the capsule like this. Now, for the learning, I can modify one picture. Be careful. The principle behind that is, you work in this groove and this whole lobe is falling medially. The principle is, say this is one blood vessel, this is second blood vessel. Once you coagulate it here, you don't need to coagulate at each cut. Once you started from this end, this lobe is used to be dislocated medially. So then you can chop it off, which is bloodless. It is done equally on both sides. To increase the length of TUR piece, if you move, A is the distance the loop can move. So the highest piece, the longest you can cut is this long. But if the prostate is large, each time you move the scope also backward. Thereby the length is increased, A plus B. Whereas A is the movement of the loop, B is the movement of sheath. In the early learning phase, one finger in the rectum used to guide if a residual lobe is left. The end of the finishing line is you need to have a clean bed, capsular fibers, good hemostasis, and the viru visible. Give me a minute, I'm just coming to the point. Then it comes to the perioperative care. We used to follow this principle. In every patient of TUR, the amount of glycine going in and coming out is measured very carefully. Even when the patient walks around in the washroom with TUR, the irrigation should not stop. Now, one point I want to tell you. While the patient is advised to go home, he should not involve in any strenuous exercise. Now, having involved in this operation lifelong, I would like to share some non-textbook issues. Please be with me. Now, for our next lectures, I will be careful. For next lectures, always I will be naming penis as spine because of Facebook. Spellings are the same, words are the same, they are intermingled. So the spine has a catheter in it and that is anchored to the iliac crest. Also, we tie a bandage to the inflation channel so that if by chance the catheter is pulled, there is no damage to the urethra. Then we tie a gauze piece here as per John Blandy's design to give traction for 30 minutes post-operatively. This irrigation goes down, then we remove the cap of the urobag, because imagine if the cap is on, the resident and nurse is sleeping, this gets full. The irrigation is coming from the top, but the drainage channel is full. Now your patient will have an overstretched bladder and bleed at middle of night. To prevent that, all what will happen, it will overflow into a dustbin underneath. This is the way I have worked. If you are also working in periphery, this is a good method. If you have round the clock smart nurses, which only few people have, then it's a different matter. Now a small journey through complications. The patient can have an extraperitoneal rupture, an intraperitoneal perforation. This is how the extraperitoneal capsular perforations will occur, which will lead to extravasation of fluid. If it is a small amount of fluid, it doesn't matter. If it is lot of fluid and infective fluid, it can form abscess, a retroperitoneal spreading cellulitis. If this is an intraperitoneal injury, this is a more serious issue because you may have cooked the bowel same time. The small ball lying on it, so you can perforate the bowel. So intraperitoneal injury demands a laparoscopic evaluation, closure of the perforation. You can see even the perforation in the bladder can be seen. The rectum has been perforated, which is the most dreaded complication. This is seen rarely, but one should be aware. Now, the insulated tip of the sheath can get disconnected after repeated use. So, the treatment is take a Foley's catheter, pass the Foley's catheter through the sheath and gently pull it out. If a loop is broken, it is good to be honest and tell the patient that this loop has been broken. Give him an example that there are a lot of people who are living with bullets and firearm injuries in their body for a long time. Even for our routine laparoscopic surgery, we put many clips. Then another complication is obturator kick or obturator jump, which can also produce perforations. And in that situation, if there is a lateral wall tumor, then such a thing happens. And when it happens like that on lateral wall, then it is better if you are dealing a lateral wall, either to take care of the patient, number 2, use a bipolar current, number 3, give general anesthesia. That is the way to prevent an obturator kick. Now, the younger friends, TUR syndrome, you read yourself in detail. This is a full question. I will not elaborate on this, and on the next sitting, when we talk about medical management, then we'll talk about TUR syndrome. Now, the late complications of transurethral surgery. Number 1 is stricture urethra. Number 2, incontinence. Number 3, circular contracture of bladder neck. Number 4, recurrent adenoma. Number 5, carcinoma in a prostatic remnant. So these are the late complications, and they do happen in good percentage of cases, and you can have also meatal stenosis as a separate entity when you have a narrow meatus and you try to dilate or do a meteotomy. And remember, if you have to do a meteotomy or you have to incise the urethra, to never do a ventral, always do a dorsal, because in dorsum there is a lot of tissue on the spine. I hope all of you from henceforth, whenever I say spine, you reassemble the words and understand where the dorsal meteotomy is done. And because if I am disqualified from the Facebook on LGS, it will become very difficult for me to live and for you to gain. So you do a dorsal meteotomy on spine. Okay. These are the complications of TURP. Now, currently, a better method, a modification of TURP, is bipolar enucleation of prostate. Like I showed you, in old times, we used to call it as dislocation of prostate medially. The purpose is the same, that you take care of the bleeders from the capsule once only. Suppose this is the lobe. For your explanation, let's imagine this is the prostatic lobe. This is the blood vessel. If you keep cutting from inside, every chip you take, you open the same bleeder again and again. And if you enter here and you take care of this bleeder here, then this lobe will become avascular. And once you've gone through the groove, then you can quickly chip through. So this bipolar is exactly a modification of the same thing. And if somebody asks you, what is the in thing today in prostatectomy? Then your answer should be bipolar enucleation of prostate. It is similar to open prostatectomy in minimal SSFA, bleeding is less. If the examiner asks you, Beta ji, what is the advantage of using bipolar? There are two things. Number one, you can use saline with bipolar. So the TUR syndrome is gone forever. Number two, you can use it comfortably with people who have pacemaker. Monopolar current can interfere with the pacemaker. Number three, it delivers near as good as HOLEP at a very minimal cost. As young surgeons, you should know the cost of HOLEP is around 1 crore rupees, whereas the cost of bipolar enucleation system with bipolar cautery should be around 15 to 20 lakh rupees. Plus the running cost is very minimal. Hence, it is getting popular. Now, let us come down to the operative part. The last procedure is open prostatectomy. Though, when you talk to any urologist, everybody says, oh, I have not done it for last 10 years. There will be people to tell you 15 years. But the guideline says, in absence of HOLEP, open prostatectomy is as effective as any other modality. Two things, Dr. Rohila, if the size is more than 80 grams and the HOLEP is not available, then open prostatectomy can serve as good. And when we look at our Indian masses, how many of commoner on the road can pay for a HOLEP TURP? I would like to revive in you the art and skill of open prostatectomy for a select group of patients. Now, few things about open prostatectomy. The bladder is exposed as usual. Now, there are two ways, transvesical and retropubic. First I will talk about transvesical. The bladder is open between two stay sutures. The spill of the urine is avoided. Now, a figure of 8 vicarial suture is tied at the vesicoprostatic junction. Why? During enucleation, your tear may not extend into the prostatic capsule. After inspecting the bladder, then we mark the prostate all around with cautery, which is also known as circumcising the prostatic gland. Then the interior commissure is divided and the gland is enucleated all around. And once it is enucleated all around, there is a change. In all previous standard books, when I say standard books, that means previous Campbell's, they said you enucleate gland all around. And then we used to take a curved scissor on the top and divide the apex with a sharp scissor. Why? This used to be an important question. Why do you snip off with a sharp scissor? The answer used to be, there are, number one, to prevent avulsion injury to the external sphincter. Number two, there is a apical blood vessel, apical artery. If it is cut, it retracts and cools down faster than if it is avulsed. Okay? So, then we pass sutures, welcome Jha, at 5 and 7 o'clock, figure of 8. If the bladder neck is there, we take a wedge of bladder neck. All these activities done, every suture being passed, you need to look at the ureteric orifices each time. You can tell your anesthetist. that he gives enough hydration, that the ureteric jets are showing their presence in front of you when you take every bite. And you need to have good dexterity to suture in the depth. And then you pass a Foley's catheter and put it on. Inflate the balloon. The posterior rim of the vesicoprostatic junction can be sutured with locking catgut or vicryl, rapid vicryl sutures. The fossa can be cauterized. Normally you do not encourage to inflate the balloon in the fossa because then fossa doesn't contract. But in rare situations, if there is very oozy, you can inflate the balloon in the fossa. And if the gland is very large, there is no harm of doing SPC because it is a safety valve against clot retention, and you leave a retropubic drain and close it down. The art of open prostatectomy and transvesical as well as retropubic. Retropubic is a similar way, but the art of suturing in the depth of periprostatic veins above and below, putting a tourniquet on the root of penis outside with a gauze to decrease the venous return. And then you incise the capsule and enucleate the prostate. Now, transvesical and retropubic prostatectomies are also done robotically. Dr. Inderbir Gill is one of the forerunners who started it, I think, a decade ago. But still the volumes are small, people are being evaluated, and there's some people saying you're trying to kill a rat with a, big barrel gun, not required. The complications of open prostatectomy are same as TURP, except one rare complication of retropubic prostatectomy, which is osteitis pubis, in which the patient develops adductor spasm. He walks with a scissoring gait. The radiological features may appear much later. So that finishes with operative steps. Now I know I'm waking you up, but you are all young guys willing to share time with me. Few important things, how the world thinks about in 2020. Now few guidelines. Few I have told, whatever I have not told, I am going to tell you. That in the first visit of the patient who has voiding disorder, he must make a voiding diary which says the number of times he voided during day and at night, and the volume at day and the volume at night, because you want to distinguish the voided each time. That tells his bladder capacity, the capacity to hold and the capacity to void. These are two different things, and we want to know whether he has a polyurea or only a nocturnal polyurea. In the ultrasound, one recent advance is that they are measuring the prostatic configuration. People who have more circular configuration intravesical, which is forming like a ring, are more likely to have retention episodes. The measurement is of intravesical prostatic bulge and the distance between the tip of the prostatic median lobe and the bladder neck. You don't need to go in that much detail. I think some really urologic buds can note it down. Similarly, measuring of the bladder wall thickness. Now, one very important information in recent advances is we need to have behavioral modification. This some of you can write, those who are interested. Number one, lot of increased frequency is when the patient knows he has enlarged prostate. The patient needs to be educated that how I tell or educate my patients when somebody asymptomatic comes with a 45 gram glands and maybe one more or two more times getting up at night. Then when he's worried, I said, congratulations. He said, why, sir? I said, only when you cross 60, you get such things. It is part of graying. So this is a part of assurance you want to say that there is nothing serious in this process. Then they should be periodically monitored. The lifestyle modifications, suppose they have nocturnal frequency, so they should take your dinner 3 hours prior to the sleep and avoid alcohol or caffeine at night. And they should have learned the art of relaxed, unconcerned about urination. Let it take 15 more seconds, makes no difference. And they should be taught to, milk their urethra so that they don't dribble after and spoil their garments. We should be adjusting their other drugs. For example, not taking a diuretic after sunset and taking care of their constipation and reassurance. These are important things. Then some guidelines are mild to moderate symptoms. Just watchful waiting is recommended. And men with LUTs will have lifestyle modifications. TURP is reserved for severe to moderate symptoms and with a prostate more than 30 grams. Offer bipolar TUR enucleation for moderate to severe symptoms and glands more than 30 to 80 grams. Open prostatectomy has good results comparable with any other modality after 80 grams. In absence of holmium and bipolar, there is a strong evidence. There is a strong evidence in March 2020 that after 80 grams, people who are not accessible to holmium or HOLEP or bipolar enucleation should have open prostatectomy. When I was taught transurethral resection, the mortality of TURP was thought to be 1 and of open was considered 6. So that in that particular era, neither we had oxygen saturation monitoring nor we had echocardiography. So a lot of people, all people who die in prostate, they rarely die from prostate. They die from their cardiovascular complications. And the next guideline is on a procedure called prostatic urethral lift. Here, endoscopically, the two lateral lobes are separated through a smooth permanent suture based implant which is delivered cystoscopically. So the advantage of this procedure is in a small gland, young patients. Remember only one thing. For you, only one thing you need to remember about prostatic urethral lift. This maintains the ejaculation normal. All other procedures, ejaculation cannot be guaranteed. So if there is somebody younger in age asking for help, drugs have failed, offer this procedure. Send him to a friend who is good in doing this. So another very strong recommendation is intraprostatic botulinum toxin A has no benefit and has no role. Prostatic artery embolization is good only in selective centers where interventional radiologist and urologist both synchronize work on a high volume center. Average technique decreases the blood supply of prostate and the size regresses by 28%, whereas around 50% patients benefited. Then the last guideline is nocturia. We need to evaluate the bladder storage capacity. There can be a global polyurea. The patient is having, no, let me admit, these terms I am hearing first time in my life when I read the guidelines. The global polyurea means more than 40 cc urine per hour 24 hours. The nocturnal polyurea is more than 20% of the total urine output at night in young patients and more than 1/3 of the total urine at night. So nocturnal anuria 20% for young people and 33% for old people. People beyond 65 who have, why are we talking about polyurea? Because we can help. Patients above 65 can be given desmopressin, but you have to be watchful for their hyponatremia. So friends, TUR is one procedure which is highly unpredictable. If we look at global figures, not more than 75% people are happy after the operation. When we say some 13% will develop stricture, some 12% will develop regrowth of adenoma if they live 10 years, some of them will be incontinent, some of them will have poor flow rate. So in total, I tell you, I don't know how the other urologist friends will share. Be clear, your TUR will bleed only on the day you want to go for a meeting, you have a dinner at your home. That is the day your prostate will bleed. Let me, before finishing, share the worst prostate of my life with you. This 65-year gentleman came in for symptomatic bladder neck obstruction and we knew he had a small gland. So we planned him for TURP. I had some guests at home and I was supposed to join them, and our first episode, how the things go wrong only in one patient. That's tragic. After giving spinal, the patient developed very severe erection. This is also one of the problems we missed, so I kept it for this case. He developed severe erection. Now, at that time, it is around 20 years ago story. That time we didn't have phenylephrine in OR to treat the erection. We tried all the gimmick we had, it didn't work out. The sensible thing in retrospect would have been to postpone that case and take him up under GA on another day. But few things you learn in life in a tough way. That is why I am sharing with you. The errors which I have done, you should not be doing. So, since the scope was much smaller than his spine, so I'm again and again reminding you, rearrange the spelling of spine in your mind with your urologic mind, because I will call it spine only till I finish this series. So the spine was so long that the shaft was, the resectoscope was only midway. So I said, anyway, we can do a quick open prostatectomy. We tried to enucleate. It was a fibrous prostate. We tore the capsule. So to control the bleeding, we packed him. When after 24 hours, 36 hours, we removed the pack, he had severe bleeding. We put the catheter on traction. In next 24 hours, he lost around 6 units. And he was hypertensive also. So I was compelled to re-explore him, and I ligated his internal iliacs. The bleeding stopped. He went home. He came back after 2 months with a painful swelling in his right iliac fossa. That was the area through which we had taken out his SPC catheter towards the left. Hence, we got an ultrasound done. The sonologist said there is a loculated collection in the iliac fossa next to the bladder. So obviously the tract was infected. He had grown various variety of organisms. So my diagnosis was he has developed an abscess. We took him up for drainage, and friends, when I opened him up, following the standard principles, when I tried to aspirate, it was all arterial blood. And this gentleman had formed an aneurysm in the iliac fossa. So he was closed up. He was sent to a higher center where they put a stent. Now what had happened, if this is a common iliac, this is external iliac. So I had ligated the internal iliac maybe a centimeter from bifurcation. And it was the aneurysm of internal iliac. So the stent was in external iliac. So somehow he temporarily got well. And later on, in the higher center only, one evening he bled tremendously into his sigmoid. This aneurysm burst into the sigmoid colon. He was explored in emergency. He underwent resection of aneurysm, resection of colon, and an end colostomy. He required in this process 68 units of blood, and he survived. When I shared this case with Professor P. Venugopal, he kept his hand on my shoulder. He said, "Sunny, you are too young yet. I have given 82 units of blood to Governor of Hyderabad who came for surgery to me." So things can go wrong with such godfathers also. So the prostate, I am trying to say how unpredictable this can behave, not because of prostate, not because of your skill, because of old population. We are all doing geriatric group, and that fellow got well, his colostomy was closed, and then I met him after 3 years with another urinary retention, and this time he had hard nodular prostate. He developed malignancy in his prostatic remnant, and then he succumbed to metastatic disease. So that is the toughest case of my life. Every person who is involved in prostate has a lot of tough experience to share, and I think that is enough for today. And tomorrow we are meeting on an interesting topic, having a surgical uncle for a young surgeon. And now whatever left in prostate we will cover day after. that is medical management of prostate and TUR syndrome. Okay, thank you very much for being with me till midnight, and all my best wishes. Keep safe, keep distance, and stay at home and read your books. This is the time for youngsters to, take care of their academics. Okay, good night. Thank you.